Hello and welcome everybody. Thank you for joining us for the final webinar in our three-part Lancet series on transplantation. And today it's focusing on policy innovations to advance equity in solid organ transplantation. This webinar has been organized in collaboration with the Lancet and is supported by the American Society of Transplantation, the European Society of Organ Transplantation, and TTS in this three-part series. I'm Jen Lee and a transplant nephrologist at Westmead Hospital, and it's my pleasure today to chair today's meeting and introduce our speakers as well. I'm delighted to welcome back Dr. Peter Reese, who leads this series as the organizer. And Dr. Reese is a transplant nephrologist and epidemiologist and serves as a founding director of the Vanderbilt Center for Transplant Science. He's a former chair of the UNOS Ethics Committee, and his research focuses on expanding access to organ transplantation and improving transplant policy. Today, we're also joined by two speakers, Dr. Elmi Muller and Dr. Lisa McElroy, who alongside Peter co-authored this third review in the series. Dr. Elmi Muller is a transplant surgeon, and she's a global leader in healthcare and transplantation. Back in 2012, the Lancet described Elmi Muller bending the rules, changing guidelines, and making history. She's immediate past president of TTS and has led policy development to eliminate human organ trafficking and increase access to transplantation. She's a past chair of the Declaration of Istanbul Custodian Group, a member of the WHO Task Force for Organ Donation Transplantation, and has implemented donation after cardiac death program in South Africa, and also led groundbreaking research and work with HIV-positive transplantation. Dr. Lisa McElroy is an assistant professor of surgery and population health science. She's the director of the Health Service Research for the Department of Surgery at Duke University. Her research aims to improve access to transplantation by optimizing processes of care, and this work is funded by various grants, including the American Surgical Association Foundation, NIH. She's the vice chair of the ASTS Grants Committee and OPTN Data Advisory Committee. Now, before I hand over, just a quick reminder to the audience, please post your questions in the Q&A box, not the chat box, so we can see and address these during the discussion. So without further ado, I'll hand over to Peter.
Thank you. It's really exciting to be here and also to represent a very talented authorship group. I think it was extremely important when talking about equity to have people from across the globe with different specialties, with different perspectives. We were very fortunate that this group here on the screen agreed to contribute their expertise and ideas. And I have to give a special shout out to Allison, who isn't here today because of some very important commitments. And this work really represents a lot of her creativity and enthusiasm. And I think when I think about this entire series, this manuscript brings it all together. And the goal here is manifold when I think of the whole series. First of all, I think there's every reason to be optimistic about the future of transplant. Like all clinical fields, we have our highs and lows and our challenges, but there are many historic problems that have made transplant difficult, and new technologies are now coming online and making meaningful, measurable, big impacts, knocking down these challenges in ways that should make our patients and us feel optimistic. So I'm happy to bring that optimistic message, and I really encourage you to share these manuscripts, which are open to access through a Lancet account, and these webinars, which are meant to be accessible, to share these messages and this knowledge with your trainees. Our trainees are in the hospital right now, and this is a great time to make the case for why transplant is the most exciting place to be in all of medicine. And so here, I think we're tackling some big questions. So as you heard with the first manuscript in the series, there are new technologies that are transforming organ preservation, transportation, organ repair, the creation of organs. And then in the second manuscript in the series, you heard from Doctors Lupi and Sablik and Kush about how if you're fortunate enough to get a transplant, there are many ways in which we'll be able to better customize and deliver precision immunosuppression, diagnose problems with the organ when things go wrong, and better target therapy. But we always have to ask ourselves, when there are new technological advances, how are they shared? And in transplantation, it's been very common in the past to ask ourselves the question, once the organ is in, how do things go? And sometimes once we have a cohort of organ transplant recipients, is there equity in outcomes? But the other purpose of a healthcare system is to bring to bring a service to everyone who needs it. And so I just want to give a little bit of structure to our discussion. When we talk about equity, we're proposing this definition, which is that every person with end-stage organ disease who could benefit from transplantation has a fair and just opportunity to receive a transplant and the care needed to thrive afterwards. We hope that organ transplant recipients are able to lead extraordinary lives and that everyone who needs it can get one. That's a lofty goal, but it's nonetheless how we're thinking about transplant equity. And I also just want to make the point that this manuscript and this webinar really is going to focus on health policies as a tool to advance transplant equity. And we think about health policies as laws, regulations, plans, and actions taken by governments in all levels, and of course, government-supported institutions to improve public health. In this case, we're talking about, for transplant. And I want to acknowledge very openly that there are many tools to advance equity that don't really fall neatly or completely under the umbrella of health policy. Equity can be advanced through bioethics, through self-reflection, self-improvement, through professional society guidelines and advocacy, through the private sector, through patient advocacy groups, for instance, and their innovations, tools they create, sometimes new drugs or new programs, new health services, they come out of the private sector and they can advance or hinder equity. So the set of tools that leads to equity and in the domain of health is broad. This article is going to try to stay in the lane of health policy. And for sure, we need to acknowledge that our goal is to be global in our outlook. And we understand that different transplant systems in different countries, and even within countries, are in different states. They have different capacities. And we proposed, based on some prior work, good thinking, coming from some World Health Organization supported meetings and position papers, just a set of categories in which we try to group together transplant systems that have different goals and different capacities. And so we call them categories 1 to 5. And we acknowledge that this took some judgment, and we, it's certainly not everyone would put it together this way. But I've listed them here, and they're in the manuscript in the table. But the idea is that some countries don't have transplant activity; they have to outsource it. Some countries are really only working with living donor transplant, and they may be supported or mentored by centers in other countries. Some countries have autonomous transplant systems, but they're really focused on living donor transplant. They haven't been able to make this major investment in deceased donor transplant. Then there are countries with category 4, with deceased donor transplant as well, and that serious infrastructure, and that enables thoracic organ transplant. And then there are countries that have a fully developed, but of course always imperfect system when it comes to equity, where there's oversight, public investment, living and deceased donation, abdominal and thoracic transplant. The main thing that I want to emphasize is that every country has equity barriers, and the sets of policy solutions that might fit are going to, of course, depend on the setting. So our goal here was just to give a framework for thinking about how solutions, in some cases, can cut across categories, but in some cases will be very specific to a situation. And then, of course, I think it is natural and helpful for us to think about equity barriers along the patient's clinical journey. And I think we're very familiar with this journey because we describe it to our patients all the time, that upstream, a person with end-stage organ disease has to come to the recognition of a clinician that this is someone who might benefit from transplant. They have to get referred. They have to go through a multidisciplinary evaluation that often involves medical, surgical, and counseling aspects, thinking about a wide range of issues, psychological issues, substance use, everything. And that requires compiling a large dossier of records. There's the transplant procedure, there's recovery, and then there's sharing care between the center and local specialists. And so I think when we look at the journey, we can also really easily picture where equity can come apart, and where new solutions from health policy are needed. So I think this is a good moment for me to ask Lisa McElroy how she thinks about this, what her focus is. She happens to practice like I do in the United States, and we have plenty of equity challenges, and she's made some incredible contributions, I think, to bringing together equity data and thinking about a part of this journey that's often neglected.
Thanks, Peter, and thanks to you all for hosting this webinar. I think this is a great topic and very timely for us. As Peter said, I'm a transplant surgeon in the United States, and in the US, we have a really long-standing national effort to collect data on patients once they're on the wait list. And we're fortunate to have that. It's really served as a foundation for innumerable advancements in healthcare and in our national policy. But for patients that are more upstream in the process, right, before they're referred for transplant and as they move through our evaluation system, there is really no national data collection effort that captures them, and very few even multi-center registry efforts. And because of that, we have a paucity of national policies that really serve those upstream challenges when we think about equitable access to transplant. And so we really continue to look for ways to improve upstream data capture and to think about reflecting in that data, not just, cardinal or core clinical outcomes, but actually health system utilization and care delivery. And I think as we think about ways to improve our access to data in those upstream phases of care, we will see, I hope, our national policy start to focus more on making sure that all patients with chronic organ disease have an opportunity to consider transplant as a treatment option. Again, we're fortunate our national transplant regulatory and advocacy organizations are working on that effort to expand the data collection as we speak. But I think it's important to acknowledge that while those efforts are ongoing, we still need to be diligent in looking for solutions to improve care and equitable care in these phases in the short term. And some potential solutions like community engagement, patient navigators are being examined at individual transplant centers and through our different advocacy groups, but we don't yet have a nationwide effort that pulls those solutions together and incorporates them into our policy. Elmi, I wonder how what we're experiencing in the U.S. Compares to what you're seeing in South Africa.
Well, thanks, Lisa. If you look at the paper, you'll get a sense that we've classified the different countries into different category systems. And we would, in South Africa, classify more or less as a category 4 system. So we would have multi-organ transplantation, both abdominal and thoracic. And we've got a mixed private-public funding model. So for us, equity is hampered mostly by the underfunding in the public sector services. but also by competing health priorities. We compete with many issues on the primary care front, for instance. And we also struggle, I think, with insufficient oversight. Although there's been a lot of work done in South Africa to improve this, it's still a problem. If you look at Category 5 systems like Spain or the USA, you all have very robust national regulation. You've got transparency. There's a huge amount of public investment compared to other places in the world. Your disparity is more within country disparity. But in South Africa, I think we've been able to do some innovative things like our HIV positive transplant, and we've leveraged some private-public partnerships to extend access to many people in the country. So our primary challenge now is to consolidate this financing, the governance, the oversight, the infrastructure, and to expand the workforce, but also, very importantly, to get our data systems in place to make this equity feasible. And then the next thing I would just like to highlight is the differences between places like we've discussed now, like the high-income countries, and countries that are categorized as Category 1 and 2. So these categories are really countries that lack deceased donor infrastructure. They usually need a lot of outsourcing. They often need procedures abroad, which brings, of course, the risk of organ trafficking and impacts on the local capacity building. If you look at countries in Category 2, they usually have got some transplant systems, but they rely heavily on international partnerships, often only living donor kidney transplantation, and therefore they face major limitations in terms of both case volume, but also ethical oversight. In this paper, when you read it, you'll see that it highlights that equitable systems require a legislative and regulatory framework for deceased donation, that we need good organization for organ procurement and allocation. And although there are countries who've done a lot to work on this, like examples are Tanzania and Ethiopia, there's still a lot of work needed to do to progressively build this capacity in Africa. And then the next thing I would just like to highlight is some of the models that's described as being very comprehensive. For instance, the Spanish model, where we have a good national system. It's combining central coordination. It's got good systemic donor identification. It's got a trained coordinator network, and they are constantly working on quality improvement. So you will see in this paper, we also talk about the opt-out legislation, and we're trying to highlight that opt-out system alone on its own does not guarantee success, and might even result in lower public trust. So for countries who are not at this level yet, we think the priority is not to adopt an opt-out policy, but rather to establish those legislative regulatory frameworks that can give the organizational backbone to support a donation system. So although opt-out policies are in some places very valuable, and I think open up several opportunities for transplantation, it's probably not the first thing that's needed to achieve good oversight in the lower income countries. And then lastly, what is needed to achieve or improve donation infrastructure? And here we think about personnel, policy. So in our paper, we emphasize the 4 policy pillars, and that is law and regulation, clear frameworks for death determination, donor authorization and allocation, organizational capacity and workforce, so creating a good organ procurement organization. Then data and transparency. So we're thinking about national registries, tracking the pathways of our patients and also tracking graft outcomes. And lastly, public engagement and financing. And here we're thinking also about education of the community, involving religious leaders, looking at things like financial neutrality for donors and affordable access and follow-up post-transplant care for recipients.
When I think about your role that you've had as a leader in international organizations and that you continue to have you seen good examples, or are there things that you hope to see in the future in terms of helping to guide governments towards, the most towards thinking about equity and focusing on equity with transplant. I don't know if you've been in that role before, if that's something that comes up with TTS or ESOT.
It's a big discussion now, and part of, if you think about what we want to do with the Lancet Commission on Transplantation, this is one of the areas we want to focus on. Because so often we see governments making decisions for patients with end-stage renal failure, and they base those decisions on the information that I think is most prevalent and possibly not always really based on outcomes. And if you look at kidney, for instance, it is the decision to set up dialysis programs and put funding into dialysis programs, and not necessarily with that in parallel build a transplant program. But it is also how you choose to run your transplant program. And in so many low middle income countries, there's a tendency to, for instance, send patients to another place to receive a transplant there. The patient then travels, the follow-up care is back in the home country. It creates opportunities for either unethical transplantation practices or transplantation practices that's not sustainable in a country where the person comes from, and it doesn't build local capacity. So it is a big problem, and I can't say there's been really good examples where this has been resolved, but it certainly is a conversation that we want to take forward now in the next 2 years in the Lancet Commission to try and come up with ideas of how can we address this issue.
You know, transplant is such a trust-based enterprise. You know, the governmental authorities have to trust that transplant clinicians are acting ethically. The public has to believe it, or else, you know, living donation, deceased donation won't advance. At every level, I feel like, you know, you need trust. In order to have trust, you need equity, and you also need transparency. And so I think that sometimes as a field, we're so focused on technological advancement, but we lose sight of the fact that if we don't have equity and transparency, then sort of the foundation goes out from underneath us. You know, I see this in the journal, you know, in the newspaper too. You know, or in journals. You know, 1 month I'll feel great because there's articles in, you know, newspapers about, you know, this is just incredible outcomes with the new xenotransplant. And then another month I'm reading about, you know, concerns about unethical behavior about donation. And so, you know, we really kind of get whipsawed in the public eye. I think, you know, a commitment to equity and transparency is the only way out of that problem.
Absolutely. And, you know, one of the biggest problems is also that there are so many places in the world where we don't have data from. And if you information, it becomes very difficult to actually even plan how you're going to move forward. So the Global Observatory has been collecting data for now more than 20 years, but there are still significant gaps. And many countries don't have good databases locally to actually support providing this data. So before you don't know what's the picture in a country, it's very difficult to even start that conversation whether the program is equitable. For instance, in South Africa, we've got huge discrepancies in terms of access to transplantation between different provinces in the country. And we're only now collecting data on this issue, and we're seeing trends that really shows us that there's a lot of work to be done.
Yeah, I think that's a really good point, Elmi. And the other part of, you know, to your and Peter's points about the importance of equity and transparency and the link to data is that it's much easier to convince a policymaker to finance an initiative when you've got good data on the extent of the problem, right? And so without that data, it can be very challenging to get this issue to the top of a priority list for a health system or a local government, or even a nationwide or international effort. So I think data is really a lot of the foundation to what it takes to build this sense of transparency, which engenders trust.
Correct.
100%.
You know, I'm just going to make the case that we need more people like Lisa in transplant because she's bringing together bioinformatics with the clinical knowledge. Lisa, do you see that, you know, any of the advancements in sort of bioinformatics capability being usefully applied to equity problems, or like sometimes one of the things I've thought about is, are there opportunities for countries with good registries to share their platform, to give it away, to sort of create it in a way that others can take it on, so that all these problems of data capture and data consistency and standardization could get easier?
Yeah, that's such a good point, Peter. I think in the consortium that I run, one of the things that we're trying to do is to publish every paper open access, right? Because our science can sometimes be restricted to the international audience just based on access to journals and paywalls, right? So it's an upfront investment on the part of the researcher, but I think open science is a huge part of what can help move the needle on this issue, around the globe. We have to write down what we're doing. We have to share it openly, right? Recognizing that it has the potential to benefit patients that we might not ever touch. And we have to try to make it as accessible as we can to the whole transplant community. I will also say that I've learned a lot from the bioinformaticians that I work with, and I would argue that all transplant clinicians could use better data literacy. So when we talk about establishing these databases, setting the stage for a national data collection effort, the technical work that goes behind that can be very complex and nuanced in some ways. And I think for those of us that are trying to advocate for improved national and international policies, having a little bit of data literacy is actually a huge benefit when you're having those conversations. So we all have a lot to learn from the scientists that work alongside us. And we're lucky in transplant in that we have a great community of engaged scientists that have decided to share in our passion for this and take this on with us.
Lisa, can I ask you, do you think the fact that we now have moved so rapidly in the AI field is going to open up opportunities to get data quicker and easier, especially from low middle income countries?
I do think that's true. One of the even further upstream issues around data is electronic health records, right? So there are also global disparities in access to electronic health records. And I think for patients that have the benefit of receiving care within a system that has electronic health records, those data extraction, collection, harmonization efforts actually require much less work if you work alongside your bioinformaticians and learn from them. The systems can be created with a lot of passive data transfer. I think for patients that are receiving care in a paper record system or an unlinked electronic health record system, that is a much bigger initiative. And it's sort of one of the foundational differences between the differences in resources that different countries have to work with. And that is a challenge in transplant, but it affects really all of healthcare delivery for the patients in those areas.
So Lisa, also just along that line with data harmonization, if one of the LMICs or country without much reporting, if they really wanted to start this, is there a core set of, parameters or metrics they really should be starting off with? And how can this be shared across the globe?
Yeah, that's a great question. I think, working towards a global set of common data elements for, equitable and transparent transplant care would be a wonderful global initiative. If you look at the data collection effort in the United States, that started as somebody's Excel spreadsheet, right? That it was not a top-down initiative. It was a group of clinicians and scientists that started a database, locally, and it was eventually picked up by the federal government. So I think, sometimes the biggest change starts in small ways locally. But I think we could do more in the higher resourced countries to work together and think about what are the core variables that are needed to really assess the extent of organ disease and then access to transplant referral and progression through the whole system. But I don't think that effort has ever been undertaken, but I would happily participate in it if it started. And I think it'd be a huge resource to countries that are trying to start their own infrastructure.
And hopefully that does happen, because data warehousing is extremely expensive and resource intensive. So that may be something for people to think about. And I
That's
guess,
true. And the final variables that clinicians tend to add on our wish list tend to be the ones that quadruple the effort for the bioinformaticians, right? So there can be an exponential relationship between number of variables and effort, which is why the core set of common data elements would be so critical, right? To spare lower resourced settings the work of extracting really complex data that may not be as useful at the population level.
and you mentioned, high income and LMICs working together. I guess collaborations that Elmi talked about, private, public. How do you think that high income and LMICs can work together outside of just data collection?
When I think about this, I really think about, sort of workforce training and development. I think this is an area where I think the transplant community really needs to think globally. There's a wonderful precedent for this in transplant. A lot of our global clinical workforce has trained at some point in their career in another country. And there's been a lot of people trained in the United States that go and establish a program in their nation of origin. My division chief is Deb Sudan, and she's helped several of her former trainees establish intestinal transplant programs in their home countries that have significantly fewer resources than we do in the United States. And so I think we know it can be done because it's been done in small ways focused on clinical care. In the United States, living donor liver transplant, it's really any success we have is due to the mentorship and training that many of our pioneers received in other countries. So I think we could broaden our perspective on this significantly as a transplant community and think not just about acquisition of clinical skills, but our administrators, our leaders, mid-career transplant clinicians that are taking on new leadership roles or retraining, advocacy groups, bioethicists. Peter mentioned the importance of trust in a transplant system, even industry partners. We can, I think, partner in very specific ways and work on thinking about all the different components of a optimized transplant ecosystem and how to adapt them based on the resources of the specific country of interest, which will then lead to sort of a coalescing of that information into broader, we have this kind of for the higher resourced countries, but we haven't actually done this for the lower resource countries. And I think it's through those partnerships that we could start to amass those adaptations based on level of resource and start to coalesce a sense of, how does a lower resource country build a transplant ecosystem that works for their patients, but doesn't consume as much resources. And I think there's a huge opportunity there.
And maybe I can add there, Jennifer, that TTS has got a global data harmonization committee, which Joe Kim is chairing. And I think they're working quite a lot now on bringing rules and regulations in terms of how you collect data, thinking about how you can let different databases talk to each other, looking at new registries and what should happen there. So it's interesting, and they also have a website which we can share with anybody who's interested.
Great, thank you, Elmi. And so I might actually then, so Elmi, Lisa, and then Peter, maybe get your view on this. Lisa's mentioned the transplant ecosystem. We've talked about data collection and also expertise, sharing of training expertise. What about all the things that we spoke about in the second webinar about new technologies. So quite a lot of barriers, and we had a lot of feedback that this was an issue that might be a barrier to implementation.
Absolutely. I think one of the things about these new technologies is that I think we kind of have two ways to think about them. One is that they should benefit the patients who have access to them. But at the same time, the distribution of those benefits could be really unequal. Because I'm a natural optimist, what jumps to mind immediately is how some of these technologies might benefit groups that I've always been worried about. But I think fundamentally we should also talk about ways that, places we're worried and things we can do. And we can never stop worrying about equity. It's just a perpetual problem. But for example, when I think about the patient who lives in the rural area, or the area that's distant from the specialist or distant from the center, this is a group you're very familiar with this from the Australian context. For instance, Nicole Scholl's one of our co-authors, thinks about this a lot. This is a patient who has to travel, difficult to get to a specialist, could be financially burdensome, could be burdensome to their caregiving responsibilities. This is the kind of person for whom precision immunosuppression and non-invasive monitoring of immunosuppression could be very, very important. So I think I'll be the first to acknowledge that there are all these competing technologies, from cell-free DNA to gene expression to urine chemokines. There's lots of them. I think some of these are going to pan out, and some of them could be even more valuable to the person who lives 150 miles from a center than the person who lives next door to the center. Because the person who's next door to the center, they have access to lots of different things. They can get a biopsy more easily. So I think we really need to work to get these tools into the hands of local clinicians, help them understand them, and try to make the cost burden lower. So I think that's an area, the sort of geographically distant patient, where I'm really hoping that advances in precision immunosuppression can help them. Now, what should I be worried about? I should be really worried that LMICs won't get access to these. The people that need them the most won't get them, or they'll get them, but they'll get them later, or they'll get them, but they'll get them in an inferior form. So I think we need to push. And, one of the things, I'm not a deep expert on this, but one of the things about cell-free DNA that does occur to me is that this is not a new technology. We did not invent it. This was already deployed and out there for a while. So it strikes me as the kind of technology where there ought to be opportunities to make it more widely available. So that's one area where I think about, that's a technology that could really have pro-equity effects. But if we sort of fall asleep at the wheel, then it might just widen the gap between the people who have and the people who don't.
Peter, it's just such another great example of the importance of partnership too, right? So for technologies that might be cost prohibitive, to LMICs, the ability to partner with industry and look at the ways in which those technologies might be delivered under a different system, or generate benefits that might not be immediately obvious in a different setting, a different system, a different level of resources around a country. That's critical information, not just for the people that are in this innovation space, right, that want their innovations to reach as many people as possible, right, but for those of us that are working to try to improve access to the best transplant care that's available, to everyone around the globe that needs it.
100%. I agree with everybody. I might just encourage the audience to put questions in while Emma keeps talking about this. Thank you.
And just to say that I think it's also important that we who work in the low and middle income countries think about what innovations would be helpful to us, because it's very difficult for people who work in other realities or companies who drive certain processes to actually come and see what is valuable for you. So for instance, if you think about machine perfusion, it's a great tool if you have a lot of old donors, and if you live very far from where your kidneys get transplanted and you have to pump organs for a long time, it's not such a needed thing if you have mostly young donors. Like in South Africa, we have got very young donors. So it is for us to think, is this investment worth it? And is it something we want to do and drive and look for? Or is this one not for us? But then there are other innovations that could be extremely valuable. So I think it's very important that some of the people working in these countries think about it and then become part of this conversation.
And actually, Elmi, bringing up machine perfusion, I've seen a lot of excitement on regional perfusion, but there's also on the other side a lot of ethical concerns about this. Would you be able to highlight or just discuss this a little bit more?
I think it's all about when are you dead and how that is perceived in different legislative and cultural frameworks. So are you dead when your heart stops? Are you dead when your brain is not functioning anymore? Are you really dead if a machine is holding up a part of your body? Are you dead if your heart stopped and then it starts again on a machine? And of course, one has to be very sensitive to different cultures, religions, environments when we talk about this. There's a lot of work being done by groups like the ISODP group. I know there was a DCD meeting last year, which was organized by, I also think, mostly by ESOT, but by multiple stakeholders in that meeting to discuss some of these issues. For me, it feels like many of these issues can be overcome if we have good education programs, if we make sure that we bring the people who are working in the field onto the same page so that they understand exactly how these technologies are working, and so that they can inform then the patients and the public they work with. So, for instance, normothermic machine perfusion, it's not something I've worked with in South Africa, but there's a lot of work being done where the heart is harvested after a period of perfusion. And as far as I can see, all these things can be overcome if you have the correct people in the room who discuss all the barriers and then come up with a good educational process to be able to drive some of these things.
And I guess you bring up an interesting point with the cultural sensitivities, which we've kind of thought more about resources, but not so much of that as a barrier to donation and transplantation. This, I think, has been an issue a lot I've seen in some cultures with living donation, the trust, like Peter talked about, and also just the religion and the culture set to donating. There's also a little bit of more hesitancy for living donation and paired exchange in some countries. Is there a way that this could be encouraged a little bit more? Because I think that's a really great way to optimize kidney outcomes or organ outcomes.
Yes, I think once again, because of technology and the way technology is really jumping ahead, the opportunities to look at, for instance, kidney paired exchange over wider geographical areas is becoming really easy. We can do virtual cross-matching. We can actually match people very well. And we have to think, what opportunities does this bring? As far as I can see, a kidney pair exchange program hasn't got that many ethical barriers, but it has got a lot of organizational tools that's needed. And if we can bring that organizational tools to places which has got patients who are waiting and cannot be transplanted, it's a wonderful opportunity to expand transplant programs. And it doesn't need complicated technology, like, for instance, what you would need for ABO incompatible transplant. It has got lower risks in terms of immune suppression and long-term immune driven rejections. So that's, for instance, a technology or a new way of thinking that would be hugely helpful. in countries that have got small programs, low middle income countries, and that doesn't actually need a huge amount of infrastructure.
I think one other thing that's really important with equity is, there's equity in outcomes, but there's also, people pay a lot of attention to like the equity process. And so I think, it's a natural thought, but it's always useful to reinforce it, is that the more you have the patients in the room, probably the better off you're going to be in setting equity priorities. And I think that this can happen on like multiple different levels. So, if you're developing a public health campaign to, promote, organ donation, living donation, the more you have the patients in the room to offer their testimonials or sort of, be a part of the effort, probably the more effective it's going to be. If I think of even like very expensive, like very high technology innovations, like, these new developments in xenotransplant, we don't know how expensive they're going to be. We don't know how easy this is going to be to scale up. But we don't need to wait to sort of make the case that we need patients in the room when we're talking about equity and we think about who's going to get these organs. With one of these companies, I know that they convened an ethics and patient advisory panel. I thought that was a really good idea. And I think that professional societies also can play a very important matchmaking role, because they often know where there are, activated, educated, and eloquent patients, and they can connect them with the, industry innovators, and they can also connect them with the government agencies who are, trying to make things more fair and equitable for patients. So I think those process issues are really good. Even if we're taking tons of efforts to promote equity through data or through other means, if the patients feel left out, they can very justifiably say this wasn't a good process.
And Peter, that's such an important consideration when you think about emerging technologies, because, innovation comes from a problem, right? And so having patients involved early on, so they understand the motivation, right, that leads to these innovations. Not a lot of emerging technology is not intuitive necessarily the day that it goes into widespread use, right? But seeing the inception and the development process might actually be a way to engender trust and help patients, actually advocate for wider dissemination of, whatever the technology or therapy is. And our advocacy groups are very powerful, I think, advocates for us and our science and our developments often.
And
Absolutely.
talking about the patient in the room with you, I might be a little bit more controversial and ask the panelists about this question. Problem for high and low middle income countries is when a patient wants to get an organ from overseas, right? Or like trapped by an organ. I have not uncommonly, I'll get a patient that goes, hey, I really don't want to wait 5 years for a kidney transplant. I've got no living donors. What is the issue really with me going and paying for an organ for someone willing to donate? I go through this, but I'd like to take your opinion and your approach, how to actually counsel this when it comes up in the clinic room.
So maybe I can start and say, firstly, it's important for patients to understand that this has got serious risks for their health. So if we look at the outcomes, and we published a paper a few years ago around adverse outcomes after organ trafficking. And if you look at those adverse outcomes, the patient is taking a risk. It's on many levels. There are infectious risks, there are technical risks, there are risks in terms of the quality of the organ that you will receive, the processes that will happen. And the outcomes of organ trafficking transplants are not as good as the outcomes of transplants that gets done in regulated environments. So the first thing is that the patient must realize this is maybe not such a good option as what you're thinking about. The second thing is that we have to counsel our patients about the legal risk. if you do this, you can get a criminal record. And the reason why we haven't clamped down on patients is because they were seen as vulnerable subjects. But if you follow the letter of the law in many places of the world, you actually can get a criminal record. And there is a lot of work being done at the moment by different organizations to actually look into this and to make it more difficult for patients to return to their countries without having issues. You might have issues in any case with your medical insurance when you come back to get your medication. You might come back with severe complications, and I think patients need to understand that. And then lastly, patients need to understand that those donors are really targeted in unethical ways, and that by doing this, you are actually taking a kidney from a 15 or a 16-year-old person who gets maybe an iPad. We know that there were some places where kids were used for organ trafficking and they were given an iPad for their kidney. Or in very other scenarios where patients get a small lump sum, the actual donor gets a small lump sum, and the vendor and people involved in the process gets all the money. So the patient must not be fooled that he or she is making a difference to a poor person. It's a complicated discussion, but I think it's important that we have that discussion first. And then if the patient is still going to do that, I think to have a more serious discussion then around what would be the legal implications when this patient comes back to you for follow-up care. And personally, I think patients who do that, they have all the information, so then they must, when they come back, take the responsibility for their actions.
Absolutely. And I think I've seen more bad outcomes than good outcomes with these situations. What about Peter and Lisa? What happens in the States? Is this a common occurrence?
I have to confess, I don't have extensive experience with it, but I think every transplant center has some experience with it. And, we certainly talk about it with our colleagues. I think some of the hardest ethical problems are when you have more than one duty. The way I'm just sort of my emotional makeup and the way I'm wired is that I see the patient in front of me and I feel like I have a duty to, be a compassionate voice for you. But we have to be truthful. We have to say exactly what Elmi said. And, we have this other duty to a system with integrity. And, we feel terrible, even though the donor, wherever they may be, is not our patient. We don't want to facilitate very, very serious, devastating outcomes for someone somewhere. So I think it's at times like this when you have these duties in conflict that it's really complicated. So my very limited experience tells me, try to be compassionate, try to be transparent, tell the patient that, I would never want to walk away from you as your caregiver, but at the same time, the system may make it hard for us to get you the care that you need. The other thing that happens is this may be just a US specific thing, I don't know, but some centers are also so overwhelmed that they won't take on the care of patients who got transplanted in another center. So it is possible that even at the center level, kind of walking in with a new transplant and a complication, that of course you're going to be able to go into the emergency room, but it may be hard for you to have the kind of sustained relationship with a hepatologist or a cardiologist or a nephrologist that you're going to need for the life of your organ.
Yeah, very well said, Peter. I don't think I could say it better. I also have not personally had patients talk with me about this, but I think I agree with both Elmi and Peter's comments about balancing the seriousness of the topic and having respect for the rights of those donors, but also trying to frame it to the patients in a way that underscores the long-term relationship that's required between a transplant center and a transplant recipient to ensure they're getting, the best benefit from the greatest benefit from their graft that they can.
Thank you. That's a really good insight. Thank you for that. Still no other questions from the audience, so I might try and last question maybe Elmi might be better for this one, for the Santander Summit. There was a lot of discussion along similar themes here. Do you mind talking a little bit more about that and, how this might be useful for the audience to have a look at as well?
Yeah, I think the Santander Summit brought together 4 working groups, and very diverse topics were brought together under the leadership of Spain. Beatriz Dominguez Gil was the main organizer of this meeting. So the first thing that came out of the summit was to stress the importance of health care in a health system, the role of transplantation, and what does it mean for healthcare and a health system to have a transplant program, because it elevates the whole system. It doesn't only mean you have a transplant program. It now means you have good infectious disease screening, you have excellent laboratory services, you've improved your radiology, you have immunological expertise. So the whole health system benefits if you have a transplant program. And the second important general thing that was highlighted was how transplantation also, not only through Sustainable Development Goal 3, which is for better health, but how transplantation also feeds into the other Sustainable Development Goals. If you think about, for instance, climate, how dialysis has got lots of consumables, uses lots of water, has got a huge impact on climate. And if you think about the fact that in global warming and greenhouse gas emission, it is now estimated that healthcare is responsible for 5% of global warming and greenhouse gases. That is more than any combined airline. But we worry so much about flying, but we don't worry about the impact that our business is making on the climate. So that was the 2 of the global messages coming out of the Santander Summit. But then there were 3 other working groups that worked specifically on issues around donation, deceased donation, and how to drive those processes. Once again, technological impact and how to make that more accessible, specifically through policy development. And the last group also looking at the ethics and more of the ethical issues that we've also highlighted in this conversation around equitability, access to transplantation, travel for transplant, etc. So I think all 4 of those papers are very useful papers to look at if you're interested in this topic. They were published in Transplantation in 2024, and you will find them under Santander, or if you search for Beatriz Dominguez Gil, was a co-author with myself on the first paper, and I think we've referenced all the other papers in our paper. So a good resource and lots of ideas in that meeting as well.
It's been so great to work on this series together. And, I think in this session, some very important themes came out about, promoting health equity through better data systems, exchanging data, international cooperation, particularly in countries like the US, but everywhere, focusing our attention on the upstream identification of patients and referral. And I think just as a field, the more that we remind ourselves that equity is it's a persistent problem, and these new technologies, we want their benefits to spread as wide as possible, the better off we'll be as far as maintaining public trust and the trust of our patients. So anyway, I thought this was a wonderful discussion.